Hello, everyone. I'm Joyce Wipf. I'm delighted to be talking with you about the eye in evaluation for clinical practice and for board preparation. So this talk is the funduscopic exam and screening for selected eye conditions, and is from a general internal medicine perspective. This is for the American College of Physicians, Washington State Chapter Board Review course. I have conducted the ophthalmology talks for our board review course that I co-directed for national ACP for about 3 decades. So I'm Professor Emeritus at the University of Washington, Department of Medicine, Division of General Internal Medicine. And the cases and examples that I'm using are from my clinical care and working with ophthalmology in putting some of these talks together. I'm a general internist doing both inpatient and outpatient practice my entire career. I have no disclosures or conflicts of interest statement. So we're going to cover funduscopic exam and selected eye conditions. And I appreciate that most of us are no longer dilating eyes or looking at the fundus, although it is still a part of the full physical examination. And I do think there's some things we need to know and understanding how, just a primer on the exam and what do we really need to know in primary care and GIM. I would suggest one, recognizing what's normal, and helpful to know the basic findings of common retinal diseases, recognizing papilledema, because if we're working in urgent care or emergency department, we are going to see patients with acute headache and can look at the back of the eye without dilation. In glaucoma, I think at least being aware of screening recommendations for glaucoma, referring for periodic exam and recognizing which patients are at highest risk, and then guidelines for referral for diabetic retinopathy screening. All right, so just to remind us about funduscopic exam techniques, think of it as looking through a window. The best view is going up close. You can wear your own glasses, otherwise you have to do the correction on the funduscope for your own vision as well as the patient's. And you generally want to examine the patient's right eye with your right eye and left eye with your left. However, if you have low vision in one eye, use your best eye and have the patient look over your shoulder. If they look right into the scope, they're going to see the macula, and then their eyes will immediately constrict and you won't see anything. So generally starting with turning the disc on the funduscope to plus 15 diopters, view from about 12 inches away, which allows you to view the orange-red fundus reflex. Then you reduce to 10 diopters, moving in closely, gradually dialing down from plus 10 across 0 to minus 15 until the disc comes into view. The green filter, which you might wonder why is that there, can be helpful for viewing hemorrhages. I'll show you another image more close up of that. And then looking at the macula last. So telling the patient then finally when you're done looking into the light, the pupil will constrict. And as I said, without dilation will be more difficult. You can practice, especially I like to tell our students and residents, practicing with pets. Cats have tens of thousands more rods and cones, allowing them to see in lower light, and maybe they will be willing to let you look in their eyes, is something that can be helpful. There are newer scanning ophthalmoscope options that offer better view without dilation, are of course much more expensive, but do give at least 5 magnification of the usual ophthalmoscope. So if this is something that you do in your practice, that's worth considering, depending on the situation of patients you're seeing. This is the using the green filter, and you see how prominently the vessels are. I'm going to go through normal just in a moment, but here you see the disc. And the whitish center circle is the physiologic cup. The vessels come off slightly the nasal side, that's normal, of the disc. And then the vessels come off to frame the macula, which we can't actually see well on this view. So that's the nasal side. The macula is on the lateral side here. So we're looking at it as we're looking at the patient. So this would be the patient's left eye. Eye drops for pupil dilation, the most common used is tropicamide. In ophthalmology, and optometry often add phenylephrine as well. We'll have blurring light sensitivity afterwards. So bringing sunglasses, eye clinics usually have disposable ones. And then caution regarding driving because the duration of the blurred vision and marked photosensitivity is usually up to 4 to 6 hours, but may last a day. So let's go into cases. Case 1, a 26-year-old female presents to the emergency department for evaluation of severe headaches for 2 days. Headaches intermittently present for years, worsening the past 6 months. She has had no vision loss but has mild photophobia when the headache is severe. She denies fever, respiratory symptoms, postnasal drip, or facial pain. Medications include oral contraceptive. Blood pressure 140/90, pulse of 80, skin normal, neuro exam non-focal, and her fundus we'll look at close up. So take a really good look at this. So as with the other image, we're looking at the disc, the central physiologic cup, the vessels coming across, and this is the region of the macula. So with that presentation of increasing frequency of headaches and this fundus exam, I'll ask you in case 1, what is the most appropriate management of the patient? A, obtain an MRI scan of the head to rule out tumor and multiple sclerosis. B, obtain a CT scan to rule out subdural hematoma and tumor. C, work up for pseudotumor cerebri, which is now termed idiopathic intracranial hypertension. D, obtain a neurology consult. E, treat with analgesics and follow up with her primary physician soon if headaches persist. So which of those do you want to do? All right. So I can tell you most people will pick C, and the correct answer is actually E. Treat with analgesics and follow up with their primary physician soon if headaches persist. These are benign headaches. There's no vision changes associated, and especially importantly, the fundus was normal. So although it's a board style question for board review prep, and we think what's the most unusual thing they could ask about, I'll show you in a case in a moment about about idiopathic intracranial hypertension. I still say pseudotumor cerebri, but this was not consistent with that. So comparing a normal fundus to papilledema, and I will say for this particular talk, I think this is one of the take-home points to really imprint on your memory, what does papilledema look like? So we've talked about the normal fundus, and now here's papilledema. So with edema of the disc, you see the blurring. You can no longer distinguish the central physiologic cup. There's blurring of the disc retinal margins, and the vessels look like they start and stop because of the disc. Whereas you see here on the left, the vessels come off very sharply. There is a slight on the normal blurring of the disc retina margin on the nasal side. That's normal, but you can also see that it still is much sharper, more distinct than this side. So this is papilledema. So in our particular patient, headaches in reproductive age women, incidence of oral contraceptive associated headache, 600 and 100,000. Incidence of IIH is 3.3 in 100,000. And most importantly, the case was not consistent with that. Patient also could have had, for whatever reason, increasing tension type headaches not related to meds. So example of a patient with IIH. A 26-year-old female presents for evaluation of severe headaches for the past 6 months. She also reports short 15 to 30-second episodes of transient vision loss occurring several times a week. She has frequent nausea but no vomiting. On exam, Vitals may be the same, skin, acne, fundus shown, neurologic exam, and medications, isoretinoin, which has a black box warning for papilledema. And here is an image of a patient who had IIH with papilledema. And we see here again this marked blurring of the disc. Can barely make out the physiologic cup and the with the edema, blurring of the disc retina margins. This case also shows these fluffy white infiltrates, and that is cotton wool spots, which is a microischemia of the nerve fiber layers. You're going to hear me mention this several times because this is seen in significant retinal disease in a variety of conditions. So that's pseudotumor cerebri or intracranial, idiopathic intracranial hypertension. So just to talk about papilledema for a moment, swelling of the optic disc seen in a variety of conditions with increased intracranial pressure. In addition to the case we mentioned of IIH, systemic hypertensive crises, this is going to be the most severe eye finding. Brain tumor infection or trauma, and then selected spinal conditions are also a potential cause. Findings on fundus exam, edema, the optic disc, the blurring of the disc, hard to see the central physiologic cup. Vessels appear to start and stop, so they don't come off the center or adjacent as easily seen. And then I've already mentioned several of these things. The retina may have cotton wool spots with the microischemia of the nerve fiber layers. The other thing to mention is there is loss of spontaneous venous pulsations, which is a sign of increased intracranial pressure. There's a video on YouTube. Some colleagues in Canada, I believe it was Toronto, had a video and program trying to help people identify loss of spontaneous venous pulsations at one point. And there are still videos available if you want to try to look for that. However, I think most of us are just trying to see some of the basic anatomy. So moving on. Case 2, which of the following is an early sign of retinopathy and hypertension? A, arteriovenous nicking, B, macular edema, C, cotton wool spots, D, Ross spots. I think this will be pretty straightforward. The correct answer here is AV nicking. So what is that? So if we're looking here close up of the vessels of the retina, we see the wider venule and then the more narrow, clear, it almost looks clearish, arterial that it's overriding the vein. And as you get atherosclerotic plaque developing, that arterial becomes heavier and basically resting, looks like it's nicking the venule. So that's the earliest finding, really. And then as you get more atherosclerotic plaque, the arterial develops more of a shiny aspect when the light's shined on it, that you can see copper wiring here, and then silver wiring even more severe. A couple examples from the retinal physician website. Then with more significant retinopathy from hypertension, as I mentioned, others you can see cotton wool spots. And this is an example of a patient with hypertensive retinopathy, cotton wool spots. And then the most advanced finding would be papilledema, which we've already talked about. Case 3, which of the following should be part of evaluation of this retinal finding? A, abdominal aortic ultrasound. Well, first let me point this out. So we're looking at this. I'll show you a close-up of this in a moment. This whitish area along this vessel. So if this were seen on retinal finding in ophthalmology, let you know that for workup, would you evaluate including A, abdominal aortic ultrasound, B, carotid duplex, C, non-contrast CT scan of the head, or D, a chest CT angiogram. I believe I have a close-up. I'll give you a hint. These are described as kind of boxcar, whitish area seen in the artery. So the correct answer here is carotid duplex. So you may recall, so when you have emboli in the ophthalmic vessels, this is called a Hollenhorst plaque. So this boxcar appearance, as the embolus is moving along, they will ultimately break up. Sometimes as they break up, there can be hemorrhage in that area, but it's a sign of embolus to the eye arteriole. So checking to see, first thing with carotid duplex, to see if there is atherosclerotic, if there's enough occlusion or narrowing of the from plaque, that there could be emboli. There's other more advanced techniques, but they weren't included in the choices. So vascular occlusions are an important cause of sudden severe vision loss and are an ophthalmic emergency. So this is an example of central retinal artery occlusion. As we're looking at this image, I think what's most impressive here is just how pale the retina looks, and that's because of lack of blood flow. Now the macula, which is we're seeing right here in the center of the image, and would be in the center, right, if we're looking at the patient directly, is actually, it's called a cherry red reflex because there's other vascular supply to the macula, whereas the rest of the retina is very pale. So it doesn't look that dramatic, but it is very dramatic, sudden, severe, if not complete vision loss on that side. And that's an emergency. Now, central retinal vein occlusion also has significant vision loss, but it's usually occurring over hours or days. And the image on the retina is much more dramatic. Here you see the extensive hemorrhages of the retina. Macular edema was one of the choices that I had given you. Can see in a variety of conditions. This is an image of the macula with all of these whitish exudates appearing. And then this is laser treatment. See the burns from laser. Carefully done around the macula, in the macula, avoiding the fovea centralis. So there's a variety of conditions associated with retinal hemorrhages, and they have different appearance depending on where in the retina the hemorrhage is occurring. So I'm going to show you close-ups of the more superficial, the superficial nerve fiber layers causing these more flame-shaped, deeper rods and cones, causing dot blot hemorrhages, superficial retina causing a fluid level looking hemorrhage, and then this is a Ross spot, and we'll cover that more in a moment. So flame-shaped hemorrhages, they appear that way because of what we're seeing, as I said, in the hemorrhage in the superficial nerve fiber layer. Again, this could be diabetic retinopathy, hypertensive retinopathy. Dot blot hemorrhages deeper in the rods and cones, and they end up appearing just as dots and blots. Pre-retinal, sometimes called a subhyaloid hemorrhage. The fluid level, large. And then Ross spots are interesting. Septic emboli, here's one, and it's usually circular, but here's another one, a little bit more elongated. And there's usually a central whitish aspect. So as part of the embolus, this would require a dilated exam, obviously, to see this. Case 4. A 56-year-old man with history of type 2 diabetes and hypertension comes in for routine follow-up. He feels well, but has noted decrease in vision without diplopia. Exam, blood pressure 174/104, pulse 72. Visual acuity 20/30 on the left, 20/50 on the right with usual lenses. Extraocular muscle function is normal. Funduscopic exam shows this. So I think without dilation even we could see this. So looking at this patient, think about what you saw in the previous images. We were reviewing normal and what findings you see here. And my question is, this patient should receive the following. A, immediate referral for laser therapy in the macular region, macular edema. B, immediate referral for laser therapy of new vessel disease, proliferative retinopathy. C, routine ophthalmology referral within the next several months for background diabetic retinopathy. Or D, aggressive blood pressure control for existing hypertensive retinopathy. Since we reviewed some of these already, I think probably you're narrowing this down to B or C. So what was the finding here? So this was immediate referral for laser therapy of new vessel disease, proliferative retinopathy. So the laser is pan-retinal photocoagulation. There are some additional treatment options such as anti-VEGF, which is vascular endothelial growth factor. And VEGF is a protein that's been associated with development of new vessels and the complications related to that. So this is a really important situation that needs referral and treatment. So diabetic retinopathy is the most common cause of blindness in the US in patients between the ages of 18 and 65. And new vessel disease is one of the hallmarks of proliferative retinopathy, and it's regardless of where it's present. So NVD or new vessel disease of the disc, NVDE or NVD elsewhere. New vessels also is proliferative retinopathy. So going back, taking a step back, non-proliferative diabetic retinopathy or background retinopathy can have quite a lot of findings seen more by ophthalmology than by us. Increased capillary permeability, capillary closure and dilation, microaneurysms, arteriovenous shunt, dilated veins, hemorrhages such as we discussed, flame or dot blot. Proliferative, these new vessels that form are unstable, more likely to bleed. Excuse me. Vessels may track into the vitreous, and then complications include hemorrhage and retinal detachment. And here you see an example of a lot of new vessels. So as these new vessels form, there can be these fibrous bands can also form along these new vessels and then track into the vitreous, leading to complications. They also can develop retinal detachment. Here, the circles you see are signs of prior laser. So screening for diabetic retinopathy. One thing I think is really interesting, this slide is from Dr. Earl Hirsch, who's a renowned diabetologist who has used this slide in his talks. So the role of A1C in the diagnosis of diabetes took many years to decide exactly what A1C level should be determined as the criteria for cutoff for from pre-diabetes to diabetes. And what they ultimately used was actually the prevalence of background or non-proliferative diabetic retinopathy. So at the point at which that became more prevalent was the cutoff for diabetic retinopathy, or was the cutoff for A1C being diabetes. So when should retinal screening start in patients with type 1 diabetes? A, 5 years after diagnosis. This is type 1. B, 5 years after diagnosis once puberty. C, at diagnosis. D, none of the above. So the correct answer here is B, 5 years after diagnosis, once puberty. For some reason, patients with type 1 diabetes do not get retinopathy pre-puberty years. So these are a summary of referral recommendations. So this is based purely on the duration of their diabetes. So annual screening beginning 5 years after the onset, American Academy of Ophthalmology. ADA once the patient is 10 years or older, American Academy of Pediatrics initial exam 3 to 5 years after diagnosis once 10 years or older. So in general, it's going to be if they're diagnosed in pre-puberty, it's going to be after that. So same question with type 2 diabetes. When should retinal screening start in patients with type 2 diabetes? A, at diagnosis, B, 5 years after diagnosis, C, once the provider sees retinopathy, or D, if proteinuria and nephropathy are present. So it's a little bit easier since we see a lot more patients with type 2 diabetes in our GIM practices. So at diagnosis, and way back when, there were recommendations with physicians were doing retinopathy screenings, and then there for referral when the physician saw retinopathy, and then there were studies that showing images of background proliferative and normal patients that internists just did not have the training and experience to be able to see retinopathy. Although proteinuria and nephropathy and do track along with retinopathy, it's excuse me, let me say this again. Proteinuria and nephropathy and retinopathy do seem to track together. We don't wait until we see that for referral. So at diagnosis, type 2 diabetes. And here are the position statements from the ADA. So diabetes care updates this every 1 to 2 years, but an initial dilated and comprehensive exam shortly after diagnosis, subsequent exams repeated annually by optometry or ophthalmology, who are doing scans. We also in GIM now are doing retinal scanning annually that then are read by eye specialists more frequently in patients who have abnormal findings, or obviously if they have symptoms, then that's not screening. We're going to refer. Pregnancy, I'll cover in a moment. Less frequent exams may be considered if normal exam and well-controlled diabetes and no proteinuria. And that's where the role for serial imaging. But as we'll see later, I think patients are going to need to be seen every 1 to 2 years in eye clinic anyway. So I think we're going to be doing annual predominantly. In pregnancy and recommendations via ADA, American College of Obstetrics and Gynecology, and up-to-date recommendations, women with diabetes who become pregnant should have a comprehensive eye exam in the first trimester and close follow-up throughout pregnancy and for 1 year postpartum because of increased risk of progression of retinopathy. This guideline does not apply to women who develop gestational diabetes, as these women are not at increased risk for diabetic retinopathy. Case 7. A patient with diabetes is being considered for GLP-1 receptor agonist therapy. No known retinopathy or vision symptoms. My question here is, should the patient be referred to rule out retinopathy prior to initiation of the medication? A, yes. B, no. C, yes, if glucose is very poorly controlled, and I'll use A1C above 9 here as example. D, yes, if nephropathy is present. Now think about that for a moment and what you're doing with your own practice, where we're using GLP-1s, RAs often. So the right answer here is yes. And I'm not sure how widely known this is as a recommendation. So the the issue being raised by this question is when there's rapid improvement in diabetes control, how much do we increase the risk of proliferative retinopathy? So more than 30 years ago, the DCCT trial and others randomized patients to intensive control, which was then defined as A1C less than 7, which was shown to reduce the risk of retinopathy and improve long-term outcomes. However, there was a slight increased risk of progression of proliferative retinopathy from background retinopathy in patients with rapidly corrected hyperglycemia from poorly controlled. Back then, it was much more common for patients to have enter treatment with A1Cs in the 10, 12 plus range, much more less likely now. So newer agents such as GLP-1 receptor agonists, there's similar concern if that treatment is initiated and there's rapid glucose correction. So just reading here what I've listed, a meta-analysis of data from cardiovascular outcome studies showed no association between glucagon peptide 1 receptor agonist therapy and treatment of retinopathy per se, except through the association between retinopathy and average A1C reduction at the 3-month and 1-year follow-up. So essentially saying the same thing or similar to what DCCT trial found, that the main issue was in patients who already had some background findings and then having progression with rapid correction from abnormal to normal glucose. So the ADA standards of care, the latest statement in 2026, that retinopathy status should be assessed when intensifying glucose-lowering therapies, such as those using GLP-1 receptor agonists, since rapid reductions in A1C can be associated with initial worsening of retinopathy. So I think because those drugs are being used more and more, that is an important consideration. Case 8, a 75-year-old patient presents after failing to pass vision screening for routine driver's license renewal. Last eye exam was over 5 years ago. Past medical history includes hypertension, distant malignancy status post-curative surgery, family history, father with cataract, paternal grandparent with macular degeneration, negative family history for glaucoma. Review systems, gradual blurred vision, reading, and distance, which the patient attributed to age-related farsightedness and purchased reading glasses over the counter. So, this 75-year-old patient failed driver's license screening. Most U.S. states to pass need 20 over 50 or better in both eyes. Some require 20 over 40 or better. So this patient had vision acuity left 20 over 100, right 20 over 40, both 20 over 40. Tonometry left was normal, pressure on the left 20, right 19, and the Amsler grid was performed and fundus shown. So again, thinking about the images that we've seen and what abnormality you're seeing here. What is the most likely diagnosis? A, primary open-angle glaucoma, B, hypertensive retinopathy, C, retinal detachment, D, macular degeneration. So this is typical macular degeneration. In workup, this patient had dry macular degeneration, moderately severe without geographic atrophy. So the Amsler grid is interesting, and I want to go over this just because I think it is an important finding to feature to illustrate what happens in macular degeneration. So with the grid, with each eye, hold the grid 12 to 15 inches from, this is instruction to patients, to face in good light, wear any glasses you typically wear to read, cover one eye, and then look directly at the center dot with the uncovered eye. And what you're looking to see is there blurring of the all of the squares of the Amsler grid and where those are. So are they blurry lines, wavy, dark, or missing? And then follow the same steps with the other eye. and then can periodically repeat this at home to reassess small changes in AMD. So macular degeneration is the most common cause of blindness in people over 65 in the US, prevalence up to 20% in patients over 80, the most common in Caucasian women. Here's another example, but with more severe dry AMD, and you're seeing geographic atrophy, which is also called retinal holes. And you see here a large hole in the retina, in the macula, affecting vision. So the classic early treatment, which has been shown in trials to be beneficial, nutritional supplements in dry AMD. So just talking about that, there's no benefit in patients who have risks like family history but don't have AMD themselves or very early AMD. But intermediate AMD in both eyes or advanced in one did have a reduced risk of severe vision loss by about 20% if they took this combination of vitamins and zinc. But there's no development of progression of cataracts. So one of the more common treatments is the AREDS2. I think it's interesting that the initial AREDS preparations that were studied had beta carotene, but was shown that in smokers had an increased risk of lung cancer. So all of the AREDS preparations now, the beta carotene's been taken off the market in those, and it's AREDS2. So then what happens in macular degeneration? So starting out with dry, which is the majority of cases, and then 20% will progress to, without treatment, to wet AMD, which arises from dry, and it's neovascularization. So starting on the left side here, just talking about, I mentioned the high dose vitamin mineral complex that is used, and vitamin A, C, E, and then minerals like zinc are used in this complex. And then in January 2025, the FDA did authorize this special light therapy, authorized, not approved fully, because there was really only one trial, photobiomodulation with light therapy for dry AMD, moderately severe. Intravitreal injections now are available for advanced dry AMD, FDA approved. I'm using the brand names here mainly just because they're easier to say, Syfovre and Izervay, which may have benefit, but also have significant complication risk. So wet AMD with neovascularization, what happens here is that VEGF, the vascular endothelial growth factor, which is associated with new vessels forming, the complicated process of macular degeneration involving the retinal pigment epithelium. So anti-VEGF injections which block this growth factor, reduce vessel growth and leakage. There's multiple different types approved now. There's also laser therapy, and then other investigational that's being done. And more studies looking at benefits of less frequent injections. There's even oral therapies. I think this is really important because of the frequency. So what happens with loss of fine vision? It's really important, I think, to try to ask our patients about that. You can see a person 10 feet away, and you can't see the fine features of their face or start to see differences in color. As one retinal specialist said to me, the vision never goes dark, but you do have difficulty seeing things. And people say, why didn't you recognize me? And it does, affect the ability to drive, which we'll come back to. So screening for asymptomatic vision impairment, I think, is an important part of our GIM practice. So impaired vision, just the definitions quickly. Blindness is visual acuity worse than 20/200 with best lens correction. Significant vision loss, visual acuity worse than 20/60 with best lens correction. That's the World Health Organization criteria. The inability to pass driver's state test varies by state. Some use the WHO of worse than 20/60. Others set to fail if worse than 20/50 or even 20/40. Vision loss impairing function varies with the individual. So, how accurately do older adults self-assess vision? A survey in London over 20 years ago, stopping persons in the street, 15% of those with vision worse than 20/50, both eyes, were unaware they had impairment. And then published studies, which aren't the greatest quality, patients may be less self-aware of vision impairment with glaucoma and macular degeneration than with other conditions. I think this is an important potential resource if you're interested in this issue or wanting to better understand how it impacts impaired vision impacts our patients. More making eye health a population health imperative, vision for tomorrow, and just the impact on data of impact on low vision in older adults, reduced quality of life, increased falls, fractures, cognitive impairment, more prevalent, progresses faster, mental health with higher rates of depression and anxiety and other, and JAMA Ophthalmology 2019 on vision and mental health. And just the dependency and isolation when you can't drive, if that's been part of what you did, having to rely on others is a huge difference. So what about screening for vision impairment in older adults? And in a final recommendation statement from the U.S. Preventive Services Task Force in 2022, they had an eye recommendation saying that they concluded that the current evidence was insufficient to assess the balance of benefits and harms of screening for impaired vision acuity in older adults. And I have to say, this kind of surprises me. And hopefully, with population health tools, we can start to identify, have large enough studies to show that there is benefit to screening. So the current recommendations, this is from ophthalmology guidelines. Now, we're not talking about symptom-based referral because, of course, we're going to do that at any age. If there's symptoms, including a vision check and the exam performed when we're putting in the referral. So ophthalmology guidelines recommend a comprehensive exam at age 40 and by age 50 every 1 to 2 years. One of my cats is making noise. I'm sorry if you can hear that. She's been fed and watered. Primary care role, assessing risk factors and make a decision on whether to screen with visual acuity exam. A functional assessment is important, especially in older adults. I had a recent health exam, and I really liked the fact that they said, we're checking, do you have any impairment of your five senses? And I thought, that's interesting. You should think about how the eye works into that. So I think these are standard recommendations, every 1 to 2 years by age 50. So why is it important to do these screening referrals? This is just one study example in the Journal of Optometry. The prevalence of asymptomatic ocular conditions in subjects with refractive-based symptoms of, just wondering, thinking that they need reading glasses or whatever. So the list of ocular conditions found during routine exam of asymptomatic patients, and 26% of over 2,500 patients had at least one finding. You can read through these separately on your own, but just calling out a few: blepharitis, dry eye problems, pathology related to cataracts, retinopathy, hypertensive, and diabetic. And so I think it's just sometimes things have to be more significant before we can detect that there's a difference in our vision or in how we're functioning. Okay, case 9. A 66-year-old patient presents for new patient examination. Past medical history includes prediabetes. Her last eye exam was 3 years ago, has prescription glasses for farsightedness. Review systems, no visual symptoms. Family history: mother had cataracts and surgery for that. Sister with glaucoma. Exam: patient no apparent distress. Blood pressure 122/74. Bedside visual fields are normal. Visual acuity: left 20/40, right 20/30. Both eyes 20/30, and we'll see the fundus. So this is the retinal image of this patient. So think about what we've seen before. And I'm going to ask you this question. What is the estimated cup disc ratio? And so what the dotted lines are giving us is first the physiologic cup and then the disc. So is the percentage of the cup of the disc A 0.3, B 0.5 or 50%, C 0.7 or 70%, D 0.9 or 90%? So this is 0.7, and this is certainly not normal. So the normal fundus cup disc ratio is less than 1.2 or less than 50%. Many patients, it'll be much less than that. So this patient versus normal of the images we've seen before, where the cup disc ratio is 0.5, this patient. So this is one of the findings of glaucoma. So advanced primary open angle glaucoma, there's where you get an increasing reduction in the neural rim tissue. And so it becomes really minimal rim with a deep cup and then pallor of the optic nerve head. So here's an example of an image showing advanced primary open angle glaucoma. So this is a quite prevalent condition, and it also has an association by race and ethnicity. The source of this image is the NIH National Eye Institute from a decade ago, but more recent data is similar. So what we're looking at is glaucoma prevalence in white individuals in blue, black in red, Hispanic in green, other ethnicities, and then all. And you see by the time people get to age 50, there's been an increased prevalence, particularly in Black individuals and somewhat in Hispanic, especially as patients get older. You can study that more. So I think, I'll come back to that, I believe, in one of the slides, where by the age of 70, that Black individuals have a 2% the risk of glaucoma. So elevated intraocular pressure, 21 millimeters, is a major risk factor for glaucoma, but a single intraocular measurement is poorly predictive screening test. 50% of patients with undiagnosed glaucoma will have a pressure under 22 at the time of screening, and so the diagnosis would be missed if that's the sole screening source. And then over 15% of all individuals with primary open angle glaucoma will have intraocular pressure consistently normal, at least normal by population standards of under 22 millimeters mercury. And many with elevated IOP do not have and never will develop glaucoma. So that's 1% of the normal population have intraocular hypertension, still need periodic visual fields and other assessments. So the best combination to diagnose glaucoma is visual field testing, optic disc cupping, and intraocular pressure measurement. So coming back to the ethnicity aspects, so 1 in 50 overall individuals over the age of 50, but increased prevalence in people of color. So by age 80, up to 12% of Blacks and 6 to 8% of Hispanics. Not an increased risk in Asian populations, similar to Caucasian and other ethnicities. Family history, increased risk, sibling and parent, single pressure, poorly predictive, as I mentioned, and the exam of cup disc ratio is important. Referral based on risk factors and recommendations for comprehensive eye exam, and if suspect, by a fundus exam. So what does U.S. Preventive Services Task Force recommend for screening for primary open-angle glaucoma? This was another statement that was released in 2022, and it was an eye recommendation stating that the data was insufficient to make a recommendation based on the balance of benefit versus harm. Again, this frustrates me that this is a common enough condition that hopefully population tools in our practices, maybe there will be able to be large studies to show benefit of screening. Screening for narrow angle prior to dilation of eyes. I don't think the boards are going to go here, but I think if you are in a practice where you are doing dilation or as part of a comprehensive exam, concern for precipitating acute angle closure glaucoma in at-risk persons. So the rate acute angle closure glaucoma is, of course, an emergency, and the rate, it's rare, 2 to 4 in 100,000. There's slight increase in Asian individuals. It's still 10 out of 100,000. You see how that's 3 times others. However, it's still unusual, but is different than primary open angle glaucoma. Acute onset, rapid worsening of eye erythema with intense pain, initially halos around objects. It may follow midriatic drop into the eye, change from dark to a light room, and other precipitating medications. The intraocular pressure is markedly elevated, often above 40 millimeters of mercury, can be as high as 80. And it's a hard, firm globe on palpation. The classic DeGowan talked about palpating the eye. This is, of course, on surgery, and then just intense redness of the eye. But this is an emergency. So normal versus narrow angle, and this is from a website showing just the normal aqueous, the flow of aqueous humor. Here's the iris and the anterior chamber. And in narrow angle, that flow of aqueous humor is blocked and limits the drainage due to the narrow angle. So how can we look for that on physical exam if we were going to dilate? There is a technique called screening for oblique illumination, screening for a narrow anterior angle. So let me just walk through this briefly, and then I'll talk about the data for it. So this is in a patient or person with a normal deep angle. And so we shine the light from the lateral orbital rim across and look to see where the shadow is. If this is a nice deep angle, normal, the shadow is going to be on the nasal, on the bridge of the nose. If this is a shining again from the lateral, a shallow angle, the shadow is going to be on the nasal part of the iris. Okay. So this is where we're shining this light again parallel to the iris, and just restating, the abnormal shallow angle shows a shadow on the nasal iris. A normal deep angle, the shadow is going to be on the nose. So I used to say that there's not really accuracy data for this. I think I've seen 2 shallow angles in my career in GIM, and that was from years ago when we were doing more dilation. There was, however, a study done in China, published in 2007, showing a sensitivity of 76%, specificity of 81%. And is recommended in that we use prior to dilation. Ophthalmology and optometry are going to use gonioscopy exam. There was a nice review in Journal of General Internal Medicine in 2016, if you're interested in this, saying oblique flashlight test lighting up acute angle closure glaucoma, and it has really helpful images and detailed exam of the processes. So in a patient who has acute angle closure glaucoma, this is an emergency. Patient's going to need IV medications to try to reduce the eye pressure. These may include IV acetazolamide, osmotic diuresis, topical pilocarpine, laser peripheral iridotomy, and potentially, if the patient can't get to other treatments, anterior chamber paracentesis. All right, case 10. This may be my last case. A 41-year-old male with HIV positive CD4 count of 260 comes in for routine evaluation. He has had a few floaters, but no change in vision. What is the most likely etiology for the funduscopic eye finding? So we're seeing a more distant view of the retina, the disc here, and then we see the macula here, and the vessels coming off, and these whitish precipitates. So is the most likely etiology for these floaters A, HIV retinopathy, B, toxoplasmosis, C, cytomegalovirus retinitis, D, cryptococcus? Think a moment about that. So the right answer here is HIV retinopathy, and these are the fundus is showing cotton wool spots. I think the thought that CMV retinitis, many of you might have considered that. Generally, that's going to be in a CD4 count that's under 50. But certainly a patient with HIV having floaters is going to need an evaluation. So HIV retinopathy, far more common now. So cotton wool spots, again, we've talked about this before, microischemia of the nerve fiber layers. HIV retinopathy is one of the conditions where we see that, and other conditions we've discussed earlier in hypertension, diabetes, and others. So many patients with HIV have retinopathy, and the CMV retinitis occurs with advanced immunosuppression, very low CD4 counts. Early symptoms may be floaters. And these, you see these fluffy infiltrates tracking along vessels. This is much less common since the combination antiretroviral therapy, or CART, is now been done for many years now. There is an association of CMV retinitis with retinal detachment. So in other HIV, very advanced, other conditions with immunosuppression, these fluffy infiltrates I mentioned tracking along vessels, it may have hemorrhages, and as progresses, vessels may have these very shiny branch-like appearances. So to summarize funduscopic exam, it really is part of the comprehensive exam. There's a role in emergent and urgent care evaluation of headache for papilledema. It's been evident that we have limited skills as non-ophthalmologists in recognizing diabetic retinopathy per many studies. Thus, it should not be used to guide referrals. And there's an American College of Physicians position statement of this from way back. There's no consensus on how or whether primary care and GIM physicians should screen for primary open-angle glaucoma, insufficient evidence of benefits versus harms, as well as no consensus on screening for macular degeneration or asymptomatic vision loss. Often cited value of funduscopic exam as part of bedside exam, physical contact with patients. What I did in my career was I tried to view and recognize findings noted in ophthalmology consults, not necessarily dilating, but when seeing patients in follow-up, then I would say, do you mind if I take a look at your eyes, see what I can see, just to help build my own skills and understanding of what was happening in ophthalmology. So screening takeaways, just to restate a few things, ophthalmology guidelines, comprehensive exam at age 40. This is asymptomatic screening. By age 50, every 1 to 2 years. And the consult includes a variety of things they will do: tonometry, visual fields, gonioscopy to assess for angle, narrow angle risk, glaucoma risk, retinal exam, direct and indirect, funduscopic, other, and then especially importantly, not just diagnosis, but therapies based on diagnoses that they may be finding in asymptomatic people. U.S. Preventive Services has an eye or insufficient grading for vision screen and for glaucoma screen due to lack of studies. And there are numerous risks to vision impairment in older adults and maybe asymptomatic. And screening for diabetic retinopathy in patients with type 1 and type 2 per guidelines. The prevalence of open-angle glaucoma is 8 to 12% in elderly people of color. No easy screen in primary care, refer based on risk factors. Population panel management, electronic health record, and IT tools. The hope is that we can help identify high-risk groups and track screening and referrals. And I think you can see this. There's a lot of tools we have readily available in primary care, some in the emergency department. And then, as I said, really, how can we use technology and our panel management to help us do better with patients? Thank you so much. I would be happy to have you contact me with questions, jwipf@uw.edu, if you have things you would like to ask. Thank you so much for listening, and I hope this was helpful in board review as well as in your practice. Thanks.